Hey folks, I'm Kit Cassingham, and this is Speaker's Corner. The sleeping people don't like the lights, Jose. So March 30th is National Doctors Day in the United States, and now we're making it an international day. It's also David Austin's birthday. Happy birthday to you. David's going to talk to us about the history of anesthesia. He told me he was going to talk about sex, drugs, rock and roll. I believed him, but somebody said he didn't know anything about that, so he went back to anesthesia. So, Paul's being a comedian. Can you handle it?
Rock and roll party.
Okay. So, what's that?
Ship's rocking.
Ship. Okay, so the ship will rock for you, and you can do the rest. Okay. Now I'm all confused. I was going to make a bad point. Oh, I know what I was going to say. Let's welcome David Austin to put us to sleep with anesthesia. Yay!
Turn him on.
Nope. Do it again.
The volume on you, Dan. Jose? It might be
Jose.
the volume.
He got a thumbs. He said thumbs up.
More? Yeah? Hey! All right. Okay, that's weird. All right. All right, well, like Kit said, I'm Dr. David Austin. I've been an anesthesiologist for the last 30 years, recently retired. My career was in Florida, Massachusetts, Georgia. It was my last practice, which was... All right, okay. How's that? A little better? Okay. Well, as Kit mentioned, everybody knows what today is.
Your birthday.
And it's National Doctors Day. Now, it's the reason for that they chose March 30th is that it formerly was known as Crawford Long Day. And each year on March 30th, the American Society of Anesthesiologists, pardon me for reading it, but I've been partying all day and everything I put to memory is now gone. It's commemorated the achievement of Dr. Crawford W. Long of Jefferson, Georgia, which was only about 30, 40 miles north of where I practiced. As the discoverer of anesthesia on this day in 1842. So the first observance was held in 1933 by the Barrow County Auxiliary of the ASA, American Society of Anesthesiology, where Jefferson is located. In 1958, the House of Representatives officially designated March 30th as Doctors' Day in honor of the continuous efforts by physicians to alleviate human suffering. And of course, it's my birthday too. The history of anesthesia is a fascinating journey of medical discovery, spanning ancient herbal remedies to modern surgical techniques to ensure painless procedures. I got that right from GPT chat. Even in ancient times, there were different methods of performing surgery on the human body with less pain, which could be construed as anesthesia. Next. Did I do that right? Okay. All right. One of being, of course, the loss of consciousness from a severe head blow, blow to the head, and carotid compression, as like in the MMA. The dates you can see right there, as far as the way they were recorded. Another message was distraction. The guy could be playing chess while they operated on his arm. Then the use of herbal remedies for pain, such as opium, cannabis, henbane, and hemlock, some of which may be familiar to a few, I don't know, all administered by various means throughout the centuries. In fact, the Incans would chew coca leaves and drip the cocaine-laden saliva into wounds. And of course, the time-honored method is that of the consumption of alcohol. Sometimes you would add a little herbal mixer such as mandrake. And a fan of one of our residents here, hypnosis. And of course, acupuncture in China. The list goes on, and all had their drawbacks. So the art of surgery, if I can call it that, up to the 1840s remained limited by the inevitable and frequent fatal shock accompanying the pain of such an invasive procedure. Thus, surgery consisted mainly of amputation and excision of surface tumors and growths. The tools used in surgery were few and cruel. For amputations, only a sharp knife and sturdy saw were necessary. The mark of a great surgeon was not patience and delicacy, but speed and strength. Yeah. So the late 18th century record for an amputation of the thigh was 35 seconds. In his haste, however, the British surgeon did remove his left testicle. They didn't have malpractice back then. They didn't care that kind of stuff. So, and this guy right here, I guess in his haste, he might have removed the hand of his assistant there, or something like that. I'm not sure what this one is trying to depict. No, not yet. Okay. At the start of the 19th century, chemists in Europe and America were intently studying various gases, generated in, of course, the laboratory in an effort to determine the makeup of the universe. In Paris and Edinburgh, anatomists and physicians began to focus on the innermost recesses of the human body, on cadavers, of course, to pinpoint the cause of disease. And throughout the Western world, enlightened thought and the dawning machine age gave immediacy and renewed value to healthy temporal life. It was in this setting that inhalation anesthesia was to make its first appearance. However, in general, during the early 1800s, the inhalation of gases was reserved for amusement and occasionally to treat respiratory disease. The humorous effects of nitrous oxide, otherwise known as laughing gas, and diethyl ether were well known at the time. In fact, diethyl ether was first reported as being synthesized in 1540 by a German physician and botanist, Valerius Cortis, by distilling ethanol and sulfuric acid into what he called the sweet oil of vitriol. Sometimes it made people a little crazy. I guess that's where the vitriol comes from. University students were known to hold parties such as ether frolics. That's the bottom flavor area there. It seemed like they're having fun. And this plate, of course, the one above it, shows Living Made Easy, and was a prescription on how to scold your wife by administering nitrous oxide or laughing gas. She seems happy. I don't know. What do you think? Okay. And of course, laughing gas demonstrations and lectures were indeed a public curiosity, as you can see by that ad there. And I found this promotional ad quite amusing. I'll go ahead and read it for you. Gallons of gas will be prepared and administered to volunteers from the audience. Men will be invited from the audience to protect those under the influence from injuring themselves. Probably no one will attempt to fight. The effects of the gas is to make those who inhale it either to laugh, sing, dance, speak, or fight, etc., etc., according to the leading trait of their character. The participants will retain consciousness enough to not say or do anything they may regret. Of note, the gas will be administered only to gentlemen of the first respectability. The object is to make this entertainment in every respect a genteel affair. So they're sniffing gas, I don't know. So with that, Kit, could you bring in the nitrous cylinders, please? And I'd like some volunteers. Oh, look at all those hands going.
Only of the highest.
All right, so still participants in the nitrous oxide demonstrations noticed not only the hilarity produced by small whiffs of the vapor, but the sleepiness that ensued. The solution to surgical pain was indeed close at hand in the 19th century, but it remained unrecognized until well into the mid-1840s. As a native of Georgia, born on November 1st, 1815 in Danielsville, Georgia, and a medical student at the University of Pennsylvania, Crawford Williamson Long witnessed several of the demonstrations of nitrous oxide, as well as using ether as a parlor amusement. He noticed that bruises sustained in the rowdy atmosphere of those ether frolics by those under the influence recreationally experienced a temporal lack of pain and unawareness of injuries. Inspired by these observations, he decided to use ether for surgical procedures. Upon his return to his native Georgia, his first patient was his neighbor, James Venable, who had a huge tumor on his neck. That Dr. Long had long offered to remove, but because of his fear of the knife, had always refused, until Long offered to do so under the influence of ether, the effect of which were well known to the farmer. So on March 30th, 1842, you've seen that date before, Dr. Long removed a large tumor from the neck of the etherized patient with complete success and in absence of pain. And this, of course, became the first recorded surgical procedure under inhalational anesthesia. The fee for the operation was $2. We've done better than that, and I think it also involved a chicken. I think that was the anesthesia fee. But Dr. Long did persist in his desire to relieve pain for surgical patients using ether, and even extended its use to obstetrics. Long, however, did not publish his results or put it on Facebook or chat, Tinder, until 1849. Now, Horace Wells was the second American to discover inhalation anesthesia. As you can see, back then, word does not travel fast. He developed the idea, again, after witnessing a public demonstration of nitrous oxide. Wells watched his companion become giddy and fall off the stage after volunteering to inhale the gas. It appeared to Wells that the man didn't appear to experience pain from his fall. So Wells was a dentist in Hartford, and he wondered if the process of inhaling nitrous oxide might help him eliminate the pain of dentistry. And on December 11th, 1844, 2 years after Long's use of ether, Wells had a tooth extracted from his own mouth, while, of course, by his assistance and to test the efficacy of nitrous oxide. He concluded that he felt no pain, and he wanted to demonstrate this new painless surgery to the medical community. So he enlisted the help of W.T. Morton. We'll talk about him soon. He's a Harvard elite and his friend and former apprentice to make the introductions. So Wells demonstrated his new technique before a Harvard Medical School class. The demonstration, however, failed miserably. Nitrous is a terrible anesthetic, and was deemed humbug when the patient screamed at the first attempt to remove the tooth. Wells was jeered by the students attending and was humiliated. This, of course, prevented Wells from further promoting his work. Wells abandoned dentistry and traveled to Europe, where he struggled with depression. He later experimented with chloroform, which led to erratic behavior. So next, this brings me to the third discoverer of anesthesia. Guess what? Yes, William Thomas Green Morton, Wells' good friend. Although Morton was not the first to discover the surgical use of nitrous oxide and sulfuric ether, he is the most widely known for their use in surgery. This is largely because of the way in which he announced his work and pursued recognition. Morton practiced dentistry and first used ether in 1844 to fit a patient's new dentures, without pain, of course. And then after some experimentation, he extracted a tooth on September 30th, 1846. Later, he was invited to demonstrate his new discovery at the Massachusetts General Hospital. Up until that time, surgery of any sort was few and far between at this venerable institution. In fact, maybe only 1 or 2 surgical cases per week at Mass General. This was, of course, because of the public's fear of the painful surgical procedure, as well as the fear of post-surgical infection, from which most patients died postoperatively. At that time, going into the hospital was thought to be a death sentence. One time I read a surgical report prior to the use of anesthesia, and I couldn't find it again, but I'll paraphrase what I remember from it. It pretty much read that the patient had a large growth on the lateral side of his tongue. After the patient was seated and both arms and legs restraints applied, I took hold of the lesion using the tongs, and with one swift single slice from my scalpel, the lesion was excised. However, upon attempting to apply the hot iron for cautery, the patient broke his restraints, striking my assistants, and released himself, running from the surgical suite. We started pursuit down the hospital corridor, and were able to apprehend and restrain him with the help of hospital personnel, and possibly aided by the amount of blood loss the patient was experiencing. Cautery was immediately applied to stop the blood loss. The patient did, however, receive several service burns to the face in the application. This sort of thing changed in October 16, 1846, when Morton arrived at the Massachusetts General Surgical Amphitheater, and under the supervision of John Collin Warren, the surgeon-in-chief, successfully anesthetized the patient with sulfuric ether for surgery. Warren excised a large neck tumor quickly and painlessly. Morton's discovery was formally announced in the November 18, 1846 issue in the Boston Medical and Surgical Journal. Aware of its commercial possibilities of ether, Morton refused to reveal the makeup of his anesthetic gas, calling it the Lethian. I believe that's a river of dreams in Greek mythology. And on November 12, 1846, was issued a patent for it. Now, it soon became apparent that Morton's Lethian was diethyl ether, and although he patented a number of apparatuses to deliver ether, he received no money from his patent on the chemical compound. All right, so I'll throw that away too quick. All right. This is a picture that is hanging in the Mass General in the what is now known as the Ether Dome. It's the original amphitheater that where they did the surgery. Still awake there, Paul? Okay. And they now, which shows the surgical excision, the very first anesthetic demonstrated to the medical community, and it's celebrated at Mass General as Ether Day. So here's those three gentlemen. So at least 3 Americans separately introduced the surgical use of nitrous oxide and diethyl ether in the 1840s. Surgical anesthesia was adopted in general practice quickly, for it was simple to administer and conferred obvious and enormous benefits to both the patient and practitioner. Inhalation anesthesia was soon recognized as a great American contribution to science and medicine, and the noted physician, the poet Oliver Wendell Holmes, yeah, there it is, okay, suggested the term anesthesia. from Greek construction, meaning insensibility to pleasure or pain. The three men who pioneered the use of inhalation anesthesia and their supporters all began to vie with one another for recognition as the discoverer of inhalation anesthesia and father of painless surgery. This controversy even outlasted their lifetimes. For a while, Massachusetts, with its statue in Boston and Ether Dome at Mass General, deemed their state as the birthplace of modern anesthesia. But after years of contesting this, Georgia took that honor in the name of Crawford Long. Boston still, however, makes claim to being the first to demonstrate the use of inhalation anesthesia for the purpose of performing a surgical procedure. Demonstrate is the key word. So today, more than 48 million surgical procedures are performed each year in the United States. The safety of anesthesia has increased exponentially in the last 50 years. And with the introduction of new drugs and techniques, it continues today. Any questions? That is me, yes.
Here, Dave.
Yes.
What's the riskiest aspect of anesthesia in our time?
Well, you can liken it to like a,
Repeat the question, please.
what is the riskiest aspect of anesthesia?
In our time.
In our time now, yes. Okay. Well, that I would say is on induction and emergence, kind of like takeoff and landing. In between, see, I had a picture up there with my feet up on the anesthesia machine. That's usually the position of an anesthesiologist during the case. And all I can say is if you see an anesthesiologist relaxing, reading the paper with his feet up there, that's a good anesthesiologist. If you see an anesthesiologist who's working and actually doing something, no, he doesn't know what the hell he's doing. So, but it is likened to like an airplane flying, is takeoff and landing. Those are the times when there's a lot of variables that put the patient at risk. A lot of it having to do with the patient's airway. One is getting the airway, and the other one is maintaining it afterwards. Yes?
I had surgery a year ago. I didn't get any inhalation with a drug in my arm.
Right. Yeah, well, there's various techniques, and that's, I will repeat the question. He said he had anesthesia, but we did not use an inhalation technique. It was all done by IV. Now, there is a technique called total intravenous anesthesia, in which you don't use a drug. Sometimes nitrous is added in there because it's a great amnestic, meaning it causes amnesia. Essentially, if you don't remember it, it didn't hurt. But as far as TIVA goes, there's other things called MAC anesthesia, which is monitored anesthesia care, which is usually done with IV medications. That's kind of what people call twilight type of sleep. And so there's various aspects of that. I would have to ask a little bit more about the circumstances of your procedure to tell exactly what it was. But there are plenty that we don't use inhalation anesthetics. That on regional techniques like spinals, epidurals, or blocks in the arm, and things like that, that people are actually awake and we just give them a little something to sedate them so that the time passes by real quick. Yes, sir.
So, I don't remember anything of surgeries I've had, but is the patient awake, conscious, interacting, or are they completely asleep?
Did everybody hear that? Okay. Wanted to know if at any point in time during an anesthetic procedure, is the patient awake and interacting, or at least moving and responding to the stimulus from the surgery and things like that? Yes, that does happen. Usually it's deep in the anesthetic. But a lot of times we utilize a lot of medications, like I said, that are amnestics. They cause amnesia. And we just crank that up, of course, and make sure that you don't remember any of that. But there are times that people become what we call light, and that just depends on the amount of stimulus they're getting from the surgery, depending on how much anesthetic you're giving. You can be giving the correct amount of anesthesia, but when the stimulus increases, then you got to increase it some. As far as interaction, that usually doesn't happen unless you're utilizing what I what I just described as just light station or twilight type of thing, with a regional technique that will, of course, numb a certain area that the body is being operated on, and the rest, they're breathing on their own. And you can have a nice conversation and enjoy the surgery with the patient. So, yes.
Are paralytics common?
Yes, very common. I mean, we utilize it every time during the general. Are paralytics common? And what he's referring to is something that paralyzes the body. We do that for two reasons. One reason is to attain an airway. It makes it a lot easier if the patient's gag reflex and as well as, of course, being able to clench down their teeth are obtunded by the paralytic agent that paralyzes them, so that we can gain access to their airway. Also, it aids in surgical procedures, relaxing the muscles so that they don't have to retract as much. Because like I said, answering your question, people do react to stimulus while under anesthesia. And so they can get tight, and the muscle relaxant, of course, counteracts that. But you have to be careful in doing that, because in paralyzing a person, a lot of the signals about how light they are gone, and you want to make sure that they're still asleep. So that's where you run into the problem of what we call a recall, where a patient's awake while having surgery. It's very rare, but it does happen. Yes, Kit.
Why did you choose anesthesia as your practice?
Why did I choose anesthesia as my practice? My mom wanted me to always be a doctor. I blame her. And from there, at first I wanted to be a surgeon, but then I saw that you have to do 5 years of residency. It's kind of a pyramid program. And I saw the 5th year surgical residents, and they were like walking zombies. And then I saw the anesthesia residents, and they were partying. They had a great time. We were, so that's what I wanted to do. Plus the fact that it's a finite practice. You have your own little world with your anesthesia machine. You got your patient. You take care of that little aspect, and then when you're done, you say bye-bye. Now the surgeons, of course, they have to continue to take care of their patient and all that. And so, we're not necessarily 9 to 5, but we do have a schedule, and we show up at a certain time, and in general leave at a okay time. But we're always on call, and you never know what's going to come into the OR. But I kind of like that, the fact that it wasn't, it was a finite sort of practice. I knew exactly what I needed to do, and I took care of that.
Okay, thanks.
So I remember when people would say the most risky part of having surgery is your profession. Can you
Yes.
speak to that?
Yeah, the riskiest part of a surgery is that of the anesthesiologist. Well, a surgery can be successful, but if the anesthesiologist lets you die, who cares? We take care of the head. That's why we're at the head of the bed, and we take care of all the vitals of the patient. We take fluids, maintain their vital signs, and are responsible for all that. The surgeons, a lot of times, orthopedic surgeons, general surgeons, they're working mostly as pretty much technicians. They're taking care of that one aspect of why we're having the surgery while we take care of the rest of the body. And there are a lot of risks with anesthesia. We have one of the highest malpractice premiums out there, but it's continuing to get better and better. The risk of anesthesia keeps dropping, and with the new monitoring techniques that we have now. I mean, I started when it was just blood pressure cuff and EKG and a stethoscope. Now we have pulse oximeters, end-tidal CO2 monitors, and everything that aids us in maintaining that the patient's state during the surgery. Yes?
Hi. As far as older people coming out of surgery and being foggy for long periods of time, is there anything that you monitor that would tell you that was going to happen, or is that just something you couldn't predict?
All right, so some people, yeah, that's what I'm trying to repeat. Some people have a different sort of reaction to the anesthesia. Some people are a little bit more sleepy as a result, and sometimes it has to do with their age. And that's where the preoperative anesthesia evaluation comes in. It's where you get a sense of where they are, what sort of comorbidities, meaning other kind of medical problems that that patient has, and how it affects your anesthetic technique, and deciding on what's the best course to go with them, and whether or not you need to cut back on a certain anesthetic or change your whole technique in order to give them the best result, and so that they aren't sleeping for days afterwards. That can sometimes happen regardless. A lot of people have different, reactions. Yes, thank you, to the anesthetic. Some people have Bud Light spring water. What can I say? Yes. Oh hell, I hate redheads. Right, John? Yeah. Oh no, it is a. It's a myth that kind of bears a lot of truth about redheads. Are they different from anybody else as far as me taking care of them? And the same thing goes with surgeons. They bleed more. They just have a bad body milieu to I don't know what it is about redheads, but I've had some bad experiences with redheads. I'm talking medical, though.
That's interesting.
Oh, yes.
Favorite, least favorite procedures and why?
Favorite or least favorite procedures?
Like you saw your schedule for the day and you're like,
Yeah. It usually has to do with length. You know, I like to do a case, get out, do another one, get out, keep going. But you get those orthopedic procedures that last forever. You know, sometimes 10, 12 hours and things like that. And you just kind of like, you know, it gets, yeah, like that. Yawning. It's very boring. And one of the caveats of anesthesia is to be vigilant. And sometimes when you're in a case for, you know, a long time, the vigilance, you have to keep that up the whole time to make sure you can respond to anything that the patient does. Dysrhythmia, bottoming out on their blood pressure, and making sure the airway is still intact and everything. Because the second something happens, that's when things get excited. You gotta pull your feet down from on top of the anesthesia machine, put your newspaper down, and take care of things. So I like no work. Yes.
But isn't it true that as people grow older, the risk increases for, you know, that?
Yeah, as people grow older, their risk increases, and a lot has to do with the anesthesia. Is that there's actually a specialty of geriatric anesthesiologists, so you end up using less, and you know, you're responding to their vitals, you're responding to their how they react to the anesthetic, and you adjust it from there. Sometimes, yes, they stay asleep longer. Sometimes they're more confused afterwards. So you want to keep everything normal for them, even their temperature. Make sure their temperature is normal, vital signs are normal, so that hopefully after you're done, no harm is done. But yeah, the elderly can sometimes surprise you. And I've had plenty that, you know, take a prolonged time to emerge from the anesthesia, and it always worries you that maybe during anesthetic they had a stroke or something like that. But luckily that hadn't ever happened to me. Yes?
If someone were having a procedure and they were given the choice between conduction anesthesia and general anesthesia, which would you tell them to go for?
The choice between conduction
General anesthesia, or like a spinal
or regional anesthesia, yeah. So the choice of general anesthesia and regional anesthesia, that's been studied ad nauseum, and what it has to do with is really doesn't affect what we call morbidity and mortality, whether or not you're going to die or you have a problem with it. But regional anesthesia, let's say you do a spinal for a hip operation. and it's usually in the elderly. They're the ones that break their hips. After 6 months, a certain number may not survive. And it's the same for general and regional anesthesia. The only difference is that with general anesthesia, it occurs earlier. Okay, because there's a lot more to take care of in a general anesthetic as opposed to a regional technique. With a regional technique, you throw a spinal in, they become numb down to there, they're breathing on their own, you don't have anything to really take care of. Of course, you have to continue to monitor them. But with a general anesthetic, that's where something can happen during all the different aspects of a general anesthetic that you're taking care of. So the difference is just time frame, but still there's no difference between a regional anesthetic and general anesthetic in mortality when you look at it 6 months down the line.
What about recovery?
Recovery is
Immediate
a lot quicker with regional anesthetic. You essentially can time that easy and just say, you'll be out of here by noon. And with a general anesthetic, sometimes it's essentially in the elderly, sometimes they're not. But yeah, we have, like I said, with the advancement of drugs and things like that, we have some drugs out there that are like light switches. You give it to them, they fall asleep, you stop it, they wake right up. So you would use that more expensive drug in patients like that if you suspected that was the case. Yes?
So how do you feel about nurse anesthesiologists?
CRNA, Certified Registered Nurse Anesthetics, anesthetists. They're great. They're great. I have a really good relationship with CRNAs. I've worked with plenty, and plenty have worked with me. And
Because usually, when you have a colonoscopy, for instance, often it's a nurse who's doing that, and it's usually an IV.
that's correct.
Yeah, okay.
Yeah, no reason except for economic. They're cheaper. So, but there's just as any profession, you have good ones and bad ones, just as you have with anesthesiologists, good ones and bad. In most states, an anesthesiologist needs to medically direct a nurse anesthetist. I believe Vermont and Pennsylvania may be the exception. But there always needs to be an anesthesiologist who is overseeing the anesthetics of the CRNAs. They have to report to them and say, this is what I have planned. And needs to say there's plenty of competent CRNAs out there, just as there are incompetent anesthesiologists. Yes, Lee. Yes.
You mentioned
Pardon?
that some people are slower coming out of anesthesia
Yes.
than others, maybe elderly. Is there any work on sort of a reversing drug to put in?
Are there reversal drugs for people that that are slow to emerge from the anesthetic? Yes, there are. There are plenty of them for a lot of the medication, but most of the time you utilize the pharmacokinetics of the anesthetic, and you know that a lot of these are very short-acting, and they do go away pretty quick. If a patient continues to be asleep, sometimes you can use everything from Narcan to drugs that reverse the Valium drugs. They have come out with some reversal agents, but we generally don't utilize them. We just let the patient wake up, as long as you don't suspect anything else going on. Yes?
I guess related to the last two, my mom passed away and we thought part of it was responsible for hip surgery and shoulder surgery, like too much anesthesia in her 70s.
Yeah.
Is there a correlation?
Well, there's a correlation with both the surgery and anesthesia because it's a stress on the body no matter what. And this has to do with somebody in their 70s after a hip operation and anesthesia succumbing to or dying, I guess is what happened. Soon after the procedure? Yeah. It's unfortunate not knowing that much about it, but there is a significant morbidity and mortality in the elderly after the stress of both surgery and anesthesia.
And also just after hip fracture.
Yes, it's like 6 months after his fracture for. Yes. as far as pain regulation treatment after a surgery, yes, we handle the acute phase of analgesia for pain, postoperative pain. We handle it in the recovery room. Sometimes we're consulted to take care of it out there on the floor. But in general, unless you're a chronic pain anesthesiologist, we don't take care of these patients on an ongoing method. That then goes back to the surgeon. But sometimes we're consulted for that, and on the acute phase in the recovery room, we take care of their pain.
Have you run into people that don't respond to pain medications or the anesthesia?
People that don't respond to the anesthesia or pain medication. Well, I like what I always say is I always win. There's always more. But yeah, some people do require more analgesia. Sometimes some people require more anesthetic. The acutely intoxicated. Let's say somebody comes in and they're a alcoholic. If they're acutely, meaning they had a drink not too long ago, doesn't take much to put them to sleep. But if they haven't drunk anything, they are very resistant to the anesthesia because their liver's working overtime, and they're very used to these depressant type of drugs, meaning alcohol, and so sometimes it takes a little bit more to put them to sleep. With a good preoperative eval, you can figure out which. Yes.
Can you clarify, maybe I don't want to know the answer to this, but what you mean by the morbidity rate during the 6 months? Like what then takes the life during those 6 months? I kind of thought that once you're clear from the procedure and you've woken up, risks are gone.
All right. No, the risks, whether or not the risks continue postoperatively, even down to 6 months. For some reason in the elderly, they've done studies, and after hip surgeries, the average lifespan is about 6 months. It's getting better, but no, I mean, a lot of it, everything that goes on, it really takes it out of a person's body, and maybe there's injury that we can't detect, like to the heart, to the brain, to the body system.
A little blood loss too.
Yeah, exactly. So there's a lot of things that factor into that. I just relegated it to the stress that both anesthesia and surgery, confers. And this is the type of thing in anesthesia that we want to minimize. That's where the study that I read was all about. John, Yeah.
Well, I was going to say, having something like fall and a hip surgery and all the trauma that's involved, that's kind of like adding 10 years to your life. Your life expectancy is shortened considerably after a major trauma like that.
And when you put it down to actual numbers, that's the number I last remember them saying. I'm hoping that it's improved since then, but hip fractures are...
It's the fracture itself that's bad.
No, not necessarily the fracture. I'm just saying the stress that's put on the body as a result of everything that you have to go through, recovery and all that kind of stuff. Yes?
Is there any detriment to the body if you happen to have had to have a lot of surgery over the years? Is there any kind of effect on the brain?
Detriment to the body with multiple surgeries over a period of time. We found that anesthesia, from an anesthetic point of view, that shouldn't cause any detriment to the body. It used to be they said that we can't do an anesthetic within a week or over and over and over again, and we found that was not true. That we found, of course, in burn units where you have to take people that have third-degree burns and you're essentially debriding the dead skin off of them. And we always wondered why we did that with them awake, and that is extreme amount of pain. And so at our institution, at least when I was in training, we instituted daily anesthetic. We put them to sleep for all the surgeries, and they thanked us for it, and there's no problems from it. But again, it all comes down to the stress of both anesthesia and surgery. And what John just said, that with each stress on the body, does that cause you to decrease your life expectancy? A lot of studies show yes. And it all depends on your age. Yes.
Let's go to the rock and roll aspect of this.
Yeah.
I know you and I have had this discussion. Why is propofol so amazing, and why was Michael Jackson?
Ask Michael Jackson. Yeah. No, it's a very good induction agent. It's something that people, and that's why we use it. Oh, what's that?
What's the question?
Oh, the question is, why is propofol so good?
What is
propofol? Is an induction agent. The anesthetic is the inhalation anesthetic. But if we had to put people to sleep using just the gas, it takes a long time for it to build up a concentration for the patient to become unconscious. And sometimes it smells bad, it's kind of caustic in a lot of ways. But with propofol, we induce the anesthesia using this hypnotic agent, and it's a smooth induction of anesthesia, and then we paralyze them and intubate them. And then after that, we put in the inhalation anesthetic that maintains the anesthesia. Now, we can maintain it with propofol, but that kind of builds up in the body, and you talk about people that don't want to wake up. Sometimes propofol will do that too, because it accumulates in your fat, and thus you end up not waking up so quick. And plus, it's an expensive drug to run a whole anesthetic on just propofol. But people love the way it just soothes them off to sleep. It does sting a little bit going in.
So how is that relevant to Michael Jackson?
He used that for sleep. He used that to induce sleep, but just ordinary sleep, and so he used it for amnesia, for insomnia.
And you said if you were his
Oh, he'd be alive today. So, God, I wish he made that kind of money. All right, yes.
My question is about the future of anesthesia. I'm a real baby when I even get a cold. And I would love to check into a facility and go under anesthesiology for 4 days until I'm over my flu. Who else is with me? Is that a possibility?
Let's just go into a hospital, put you to sleep, and whatever ailment you have, by the time you get better, we wake you up then.
Yes, is it possible?
It's possible, but it's not going to happen. Too expensive. And it's a lot to take care of. You've got a whole hospital of people under anesthesia. There's a lot of anesthesiologists, a lot of nurse anesthetists. In fact, in the future, it'll be all done by nurse anesthetists. Anesthesiologists is the thing of the past. Oh, yeah. All right. There's somebody pointing over there. John. I thought this was only going to be about 20 minutes.
Controversy over lethal injections. You have to have the right combination of drugs or whatever. You're going to kill this person. Why don't they just put him to sleep and cut his head off?
There you go. Lethal injection, and they use anesthetics for lethal injections. Sometimes they used to use sodium pentothal. We don't make that anymore because it's fallen out of favor in the medical community. Doesn't behoove a pharmacy to make the stuff because they're not going to be able to sell it except when they kill somebody. When it comes to propofol, it does sting a little bit going in. So some advocates against the death penalty say that that's cruel and unusual punishment. But yeah, anesthetics are used. The cocktail is usually the propofol, an overdose of propofol, a lot of propofol, in that alone could kill you, followed by a paralyzing agent, usually Pavulon. It's a long-acting paralytic. And that's followed by potassium, which stops the heart. And that pretty much does it.
Yes? So, model, a hip fracture might take 10 years off a person's life. What about just a hip replacement?
Yeah, the stress of both the surgery and anesthesia are pretty much the same, and it all depends on the patient's age.
And it's not appropriate to say 10 years, but it takes time.
And it's never a given. It depends on the patient's health, his comorbidities, everything else that's going on in his life. You know, things that contribute to higher risk to surgeries like that.
So, among his fellow medical professionals, David is considered an expert at passing gas.
That's right. What I do for a living.
Did he get paid?
All right. Thank you very much. Well, I don't know if you noticed on my shirt, I have my children. They gave this to me when I launched here, and have my oldest and my youngest, as well as my son and grandson and my cat. So it's something online that you can send in your pictures and get a nice shirt with. I do wear it on special occasions, this being one of them.
All right. So, did you find out everything you wanted to know about anesthesia? That was a wonderful presentation. Thank you,
I love
David.
the questions having nothing to do with the history of anesthesia.
Yeah.
I knew that was going to
David's disappointed that you asked more than the topic for tonight, but you guys are like that. You're just a curious lot, and I mean that.
That'll be part 2, okay?
All right, so stay tuned for part 2. And you know, Paul even stayed awake during your talk. Oh, okay. Never mind. So there's a couple things. Tomorrow, we have 2 more chances to vote for the Global Harmony logo. The artists have made the suggested changes, and so from 10 to 11:30 at the what's it called? Excursion desk. Thank you. And then again 4:30 to 5:30. So vote often. Anyway. Oh, I was going to let them think they could vote more than once, but yes, you can only vote once. Tomorrow night, Speaker's Corner, I'm going to talk about my days as a coroner. So, a corner called The Care, Science, and Mystery. So, have a great evening. I understand there's some music in Morning Light. Siren Song is doing her thing. So, thanks for coming.